Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by breast surgeon, Dr. Patricia Wehner, who recently joined MedStar Southern Maryland Hospital Center as the new site director of its MedStar Breast Health Program. Today, we're going to be discussing breast cancer in conjunction with Breast Cancer Awareness Month, which is recognized in October, as most of you may know. Everyone knows someone, a family member, friend, or colleague who has battled breast cancer. Based on current trends and public interest, we want to help address common concerns as it pertains to breast cancer symptoms, signs, stages, types, diagnosis, side effects of treatment, survival rates, and the impact of COVID-19 on breast cancer, as well as the latest research. So stick around, we have a lot to discuss today. Give us a like, let us know that you're watching, share this with your friends and family, and ask your comments for Dr. Wehner in the comments. We'll get to your questions as well. So first, I'd like to say welcome to you, Dr. Wehner, and thank you for joining us.
Absolutely. Now that it's October, we have lots to discuss for breast cancer.
Yes, of course. Can you start by just introducing yourself to our viewers?
Yeah, so I'm Dr. Patricia Wehner. I've been with MedStar Health since 2013. Previously, I've had offices at Washington Hospital Center and at St. Mary's County, but I recently left St. Mary's Hospital to join Southern Maryland Hospital. So I specialize in all things breast, so particularly breast malignancies, so cancers, high-risk lesions, pretty much anything to do with it. I can probably help you out.
Wonderful, thank you. Well, let's talk about breast cancer, and let's just start with the early signs. Can you talk about what are the early signs of breast cancer?
Sure. So for most women, if they're going to be diagnosed with very early stage breast cancer, there's for many women no signs at all. So most of our early stage breast cancers are picked up on screening mammograms, which is why it's incredibly important for all women to go get their mammograms once a year. We recommend starting at age 40. However, if you truly have no risk, you could potentially think about delaying that to age 45. But generally we start age 40 once a year, get your screening mammogram. Screening mammograms, there's two different types. There's a 3D tomosynthesis, which has been out on the market for probably about 7 years now. It's become much more mainstream over the past 5 years. Traditional mammography is 2D mammography. 3D, which is tomosynthesis, which is offered with all of the MedStar locations that do imaging, is a better test, but it is something that you should definitely dedicate yourself to getting once a year. Signs that are actual physical signs that should concern you about development of breast cancer, skin changes that you notice that just look not normal for you, maybe the nipple's starting to pull in and it wasn't retracted or inverted previously. You feel a lump and it's kind of hard, maybe it's tender, maybe it's not, but it's new and you've never noticed it before. New nipple discharge that's bloody or rust colored. Those are all things that you should definitely find a doctor and get set up for examination and further imaging.
Thank you. And today is National Mammography Day, so a perfect time to schedule your mammogram. Thanks for that reminder to all of us. And it sounds like too, know your body and know what is normal and what's not. And when you see something, that is the time to have that conversation with your physician.
That is the absolute most basic, important thing for anything with your body. Know your body. Know what's right for you and what's not right for you. And if it's not right for you, go seek help.
Yeah, absolutely. So what are the symptoms that men and women typically experience with breast cancer?
Sure. So if we just kind of talk numbers, because men do experience breast cancer. Yep. So if we're looking at kind of projected case numbers for 2021, we will diagnose for women about an extra 281,000 new cases of invasive cancer. In addition to that, there's going to be about 50,000 non-invasive, so DCIS cases of breast cancer this calendar year alone. For men, newly diagnosed men will be about 2,700 new cases of breast cancer in men. So while the incidence of developing breast cancer, if you look at the population out of about 100,000 people, the chance, if you are a woman out of 100,000 people, that you're going to develop breast cancer is about 130 out of 100,000 people. For men, it's about 1.3 out of 100,000. So it's not zero. So it is important that men recognize that they also should be aware of their body and be aware of changes. Men's symptoms present exactly like women's. The only difference is men normally present at a later stage because of the fact that they don't have screening mammograms. So there's not images to be had every year that you can look at changes and differences within the architecture of the breast. Most men, it's picked up on palpation. So most of the time a man will notice that he has a hardened lump. Frequently in a man, it's behind the nipple. So they'll notice some changes where things just feel harder or different as compared to the other side. Sometimes they also get an inverted nipple, so the nipple pulls back and pulls in. But signs and symptoms are exactly the same. The only difference is men frequently aren't paying attention to it as much as women.
Mm-hmm. Yep. You mentioned the different stages. They're usually finding it at a different stage. Can you talk about the different stages and the different types of breast cancer that exist?
So breast cancer comes in really 5 different stages. So the earliest stage is stage 0 breast cancer, and stage 0 breast cancer is what we call ductal carcinoma in situ. The term in situ just means cancer cells within the duct of the breast. So stage 0 really refers to a stage of where those cancer cells really are confined to within the ducts of the breast. Mm-hmm. Outside of that, you then go to stage 1, 2, 3, or 4. And those are all based on invasive cancer. So the difference is for stage 0, in situ, cancer cells are growing inside the duct. Stage 1 through 4 is invasive. So cancer cells have now broken outside of that duct and they're growing outside of that duct. The difference is frequently for invasive cancers, there's kind of a tight ball of tissue that forms that you may or may not be able to feel just depending on the size of it. Mm. Early stage breast cancer is considered stage 0, 1, or 2. Locally advanced breast cancer, so meaning it's a really large tumor or there's lots of lymph nodes that appear to be involved, tend to be a stage 3. And stage 4 is consistent of metastatic disease, which means it's spread to other parts of the body rather than just the breast and the regional nodes. So stage 4 is for those patients that are diagnosed with a lesion maybe in the lung or in the bone or just someplace else that's separate from the breast itself. So those are the stages. There are then subtypes of breast cancer. The subtypes, there's a couple different subtypes, but the main breakdown of subtypes is hormone positive and hormone negative, and then HER2/neu positive and HER2/neu negative. So there are 3 types of breast cancer receptors that we will check for every invasive breast cancer. And one is estrogen positive or estrogen receptor, one is progesterone receptor, and the last is HER2/neu receptor. And each cancer can be positive or negative for each of those 3 receptors with any combination thereof. The combination of those positivity and negativity is what helps determine what treatment works for you, what type of medications you get. Do you get chemotherapy? Do you not get chemotherapy? So it kind of gives us a little bit of an look at kind of the aggressiveness of what type of tumor it is that you have growing. And so like a hormone positive cancer would be estrogen positive and progesterone positive. And a triple negative cancer would be estrogen negative, progesterone negative, HER2/neu negative.
Okay, thank you very much. Can you talk about the difference between DCIS and invasive disease?
Yeah, so that's a little bit of what I was just explaining with staging of cancers, of what's considered a 0 versus a 1, a 2, a 3, or a 4. There is some controversy over DCIS. So ductal carcinoma in situ, we do still characterize it as a breast cancer. It's characterized as a stage 0 breast cancer. There are some people out there that suggest that maybe we're over-diagnosing DCIS, and the reason is our pictures, so mammography has just gotten much better. It's much more sensitive. We can pick things out of a breast much better now than we could 20 years ago, just because our imaging is better. So there is a lot of question of, for DCIS, you know, if we never found it or we never treated it, would it ever actually harm somebody? And the answer is yes, some of them absolutely will, but I'm sure some of them probably could be there and cause you no harm if we left it in place over the next 5 years or 10 years. So MedStar Health is actually participating in a national-wide trial that's called the COMET trial. There are national and international trials that are looking at this. So for certain DCIS, so these early stage breast cancers, rather than treating them first line with surgery, we're enrolling them in a trial that's looking for some of these really favorable small low-grade DCIS. Can we treat it with a pill? So can we treat it with like just an anti-hormone pill and just watch it and see what happens? And so patients are coming in, they get mammograms every 6 months. And if it changes or grows, then we revert back to surgery. And if it doesn't, then we just continue to watch them and continue to just treat them with medications. That sort of stuff doesn't hold true for invasive cancer, but so they're slightly different beasts, but mainly it's the in situ is just confined inside the duct of the breast.
Mm-hmm. Thank you. That's fascinating. I did not know that MedStar was doing that, and that's very innovative. And you can just see how things have progressed in the latest research and what we can do now when it comes to breast cancer. It's just really fascinating. Can you talk about inflammatory breast cancer?
So inflammatory breast cancer is a very, very specific type of breast cancer. We don't see it that often, so it's not something that many women get, but it is a very aggressive, very rapidly growing type of breast cancer. Inflammatory breast cancer is if you go onto Dr. Google and you Google any type of lesion on your breast, you're probably going to get diagnosed with inflammatory breast cancer because it's the one thing that women all the time come in asking if they have it.
Right.
Inflammatory breast cancer does look like a really bad case of mastitis. That's the easiest way to explain it. So if you know somebody or you yourself at some point were breastfeeding and developed mastitis and your entire breast kind of swelled up and it got red and it got hard and firm and tender and it just looked very different than the other breast, that is inflammatory breast cancer. And on top of that, frequently you'll get a lot of lymph nodes which live underneath the armpit. And those will get really big and enlarged. So you'll feel kind of a really large, hard, firm ball in your breast. The skin on the breast is going to look swollen. There's going to be some skin discoloration or some redness, and likely you're going to feel some hard stuff underneath your arm. For inflammatory breast cancer, this transition from completely normal to not normal can happen pretty quickly. Quickly in the world of breast is over a few months. But so you can notice a change and then over a month or two, rapidly notice a difference. And so that's inflammatory breast cancer.
Thank you very much. That's really helpful. And yeah, I like your Dr. Google reference. I know a lot of us do that. Can you talk about Paget disease? What is that?
So Paget's disease is the other thing Dr. Google is going to tell you that you have. Because Paget's disease essentially is a rash of the nipple on the breast. So when people complain about having itchy nipples, the first thing they Google is itchy nipples, and Paget's disease is what will show up if you Google itchy nipples. Essentially, it is a type of cancer that happens in the breast, and the signs or symptoms of it frequently are changes to the skin around the nipple and the areolar complex. So you'll get kind of a rash-like experience where it'll be kind of sandpaper-ish. It's not going to look like the other breast, always compared to the other breast. So you'll notice, the sensation might change. It might be really itchy. The color of the skin's going to change a little bit. The nipple may invert, it may not invert, it'll crust over. So it's just really very localized focal changes that show up to the nipple and the areolar.
Okay, thank you. Going to pause for a moment just to welcome our newest viewers. If you're just joining us, thank you. I am joined by Dr. Patricia Wehner, who is the director of the MedStar Breast Health Program. We've talked about breast cancer signs and symptoms, the stages, so you can always watch the replay if you missed anything. But we do have some audience questions for you, Dr. Wehner, before we move on to our second set of questions that we've prepared. The first question is, if someone is diagnosed with breast cancer, is it standard procedure to offer genetic testing if the mother died of ovarian cancer and the aunt of breast cancer?
So genetic testing is definitely individualized. In that particular case that you just talked about, yes, genetic testing frequently is offered. Genetic testing is looking at, do you carry an inherited mutation that puts you at an increased risk of developing breast cancer, developing a future breast cancer, or developing some other type of cancer, dependent on what that genetic result shows. Genetic testing is either a blood test or a saliva test. It just depends on which one is done. And so it's a pretty simple test to get. The problem is not all insurance companies cover it. So, if you've got a strong family history, most insurance companies will cover it. However, if you have no family history and you're older, say you're like 79 and develop breast cancer, there's no true indication for genetic testing in those cases. And so it may not be covered. Now, with that said, we use a very particular company in our office that does pretty upfront and straightforward financial disclosures. So the cost of the test is no longer what it used to be. It used to be thousands and thousands of dollars. It can actually be done much cheaper. So even if for whatever reason you don't actually meet guidelines and criteria for testing, it can be done if you want to pay out of pocket for it. The problem is, genetic testing, we're just looking kind of at the main genes. We don't know everything yet. So you can always get a result too that's classified as something called a variance of uncertain significance. BUSs right now, we act as though they're negative just because we don't have enough information on what they are, and they get reclassified all the time of either active or non-active. But for some women, yes, genetic testing is recommended, but it's not going to be for every woman that comes in with a diagnosis of breast cancer.
Thank you very much. Another audience question for you. Is it safe to take blood pressure on the arm where you've had breast surgery?
So that's also a really great question, because historically, if you had any type of axillary surgery, so if you had a sentinel node, if you had axillary dissection, it used to be told to stay away from that arm. So the concern is if you did anything to that arm, you were going to develop lymphedema or swelling from the lymph system in that arm. And so a lot of kind of old school physicians, and you'll hear some older nurses and stuff also say like, oh, don't touch that arm, don't touch that arm. It's actually not true. If you've not developed lymphedema yet, and you are a few years out from surgery, feel free to take a blood pressure on that arm. It's not going to do anything. It's not going to cause you lymphedema. You can get a blood draw on that arm if you need to. Not going to cause you lymphedema. Now, I do tell patients to try to stay away from activities that could put them at an increased risk of developing an infection on that arm. So if you're going to garden, wear gloves, They used to say, don't lift weights. That's now proven false too. Please lift weights. Go be healthy. Go do whatever it is that makes you happy in the gym. But just because you've had surgery there doesn't mean that you can't utilize that arm. So blood pressures, blood draws, lifting weights, all of that's completely safe.
Thank you very much. Another question for you from Annie. Thank you for your question. Do 80-year-olds need a mammogram?
So this sometimes is a little bit of a point of contention, right? one 80-year-old is not the same as another 80-year-old. So if you are a fairly vibrant 80-year-old and you're otherwise healthy and you're not bedbound and you haven't, you don't have a lot of comorbidities that potentially is going to cause you to die from in the next 5 to 10 years, yes, go get your mammogram. Just because you're 80 doesn't preclude you from getting a mammogram. It's your health status as a whole is what precludes you from needing a mammogram or not needing a mammogram.
Makes sense. Thank you very much. If you have other questions, please share them in the comments. I have some questions for you about the breast health program at MedStar Southern Maryland Hospital Center. Can you talk about how breast cancer is treated and what options are available?
Sure. So MedStar has a full multidisciplinary approach to treatment of any type of breast cancer. For most women, when they're diagnosed generally from either an ultrasound guided biopsy or a stereotactic biopsy. Ultrasound guided biopsy just means that when they go into the imaging and the radiologist takes a small piece of that tumor, they're doing it with an ultrasound machine to help guide them. Alternatively, if you can't see it with an ultrasound, then we do it with the mammography machine. So that's called a stereotactic biopsy. Mm-hmm. Once the patient has pathology, then we'll have the diagnosis of if it's positive for breast cancer. And so most of the time, the first referral is to see the surgeon, who's myself, and we kind of start the entire workup and start kind of introduction to our team. Depending on what type of cancer it is, depending on the size of cancer, depending on kind of what's going to make sense for the patient from a surgical standpoint, we'll discuss whether or not the patient needs a lumpectomy or a mastectomy. And if they need a mastectomy, are they a good candidate for reconstruction? So do we need to send them to a plastic surgeon? Mm-hmm. Based on pathology, we'll decide, does the patient need to see a medical oncologist and should they see them right up front? Or maybe is it something that we should wait till after surgery? All patients, with very rare exceptions, will meet with a medical oncologist. The medical oncologist is the one ultimately who prescribes chemotherapy regimens, endocrine therapy, which is a pill that you take after surgery if you're hormone positive, but they will be the ones that do that. Patients who need radiation therapy, so if we conserve breast tissue or if they have a really large tumor, they will need radiation. So they will also be referred to meet with a radiation oncologist who will talk to them about the specifics of radiation. We also refer patients to a rehabilitation team. One of the big things with any type of breast cancer is you want to get through your treatments and come out on the other side just like you were before you went into treatments. So if there's anything that we're going to do that potentially is going to negatively impact your outcomes, we'll make certain that we bring PT and OT into the picture. They're great for education. They're great for showing you just kind of stretching exercises. We do baseline measurements to make certain that you're not developing lymphedema. And then we also have psychosocial support. For every center, we meet at least every other week, if not weekly, to discuss all of our new breast cancer patients. We talk about, are there any new research trials that should be offered to the patient that they qualify for? So it is definitely a very large team that goes into taking care of your breast cancer.
Thank you. That is really helpful to understand the different options and how you work as a multidisciplinary team to give the patient the care that they need depending on what their individual diagnosis is, the treatment that you see is the best for them, and even all the way through. Anybody after surgery does want to be able to get back to a pre-surgery normal kind of life. So it's really great to know that that's also part of the process and considered. Another question came in from our viewers from Deborah. She is asking us, it's a specific question about atypical ductal hyperplasia. Mm-hmm. So I don't know much. If you could explain what that is, perhaps that would be helpful for our viewers. But she asks, how much does atypical ductal hyperplasia increase your risk for cancer?
So atypical ductal hyperplasia is looked at a high-risk lesion, right? So it means that if you looked at a spectrum of changes that we see in the breast, if you were to look at it under a microscope, there are kind of normal changes, so just what the breast tissue should look like. There are things called proliferative changes, which means it's still, in the realm of normal. Then there's atypical changes, which means we're seeing cells that don't look 100% normal. And then as you progress past that spectrum is when you then start seeing ductal carcinoma in situ and then ultimately invasive cancer. So ADH is basically a precursor for cancer. So anytime we see atypical ductal hyperplasia, we will recommend a surgical excision because you want to make certain that there's no cancer cells associated with it or living near it. So if you have a core needle biopsy and you come in and it says atypical ductal hyperplasia, we will talk to you about a larger excision because there is up to a 20% risk of any atypia that's found on core needle. That if you went to surgery, there's a 20% risk of actually finding further cancer cells that surround that. Now, if all of that's negative and you just have atypia, you're at twice the risk of the average population then of developing a breast cancer in your future. That risk may even be a little bit higher depending upon your own personal risk, family risk. So there is a couple more things that go into that. But ADH alone does increase your risk of developing breast cancer twofold past the average kind of patient population. So for those patients, we do frequently recommend screening them at a higher level. Lots of those patients get annual mammograms, but also get an MRI once a year of the breast for further evaluation. But it is important that if you've had it, that you are screened at a higher level. Additionally, some of those patients qualify for taking a risk reduction medication to help lower their risk back to kind of average risk. So there is a lot of discussion that goes around ADH.
Thank you very much. That's really helpful. Thanks, Deborah, for that question. Dr. Wehner, what are the survival rates for breast cancer?
So survival rates for breast cancer are pretty good. So in the cancer world, we talk about 5-year survival rates. And the reason we talk 5-year survival rates is because a cancer that has a really high 5-year survival rate is obviously good. One that has a really low one, obviously bad. And so when we look at cumulative numbers, there's something called the SEER database. It's kind of a national database, and that's where all these numbers come from. So for an early stage local type of breast cancer, the 5-year cumulative survival rate for that is like 99%. So most women in 5 years after they are diagnosed are alive and healthy and not having any issues. For women who have really locally advanced breast cancer, so we're talking kind of stage 3, really large, really big lymph nodes, the 5-year survival rate for that drops down to about 86%, but still that's a pretty good 5-year survival rate. Metastatic disease, so women who are diagnosed up front with lung mets or bone mets or something like that, that drops down even lower. About a third of those women are still doing pretty well at 5 years, which means about 2/3 aren't. Now, all of these numbers that I'm giving you, though, are for cumulative risk. So this doesn't necessarily take into account the specific subtype of the breast cancer that somebody has. But that can affect those numbers a little bit here and there also.
Thank you very much. So what advice do you have for those breast cancer survivors out there?
So survivorship is a long-term game. We know that there's a handful of modifiable risk factors. Being healthy, so diet, exercise, trying to bring your BMI down to a healthy level of BMI. For postmenopausal women, limiting the amount of alcohol that they intake and trying to keep that to no more than kind of 1 to 2 glasses a week. Those that are moderate to heavy drinkers and postmenopausal are known to have an increased risk for development of breast cancer. Stay on top of your own schedule. So if you want to pick a date each year, whether it's the beginning of summer, whether it's your birthday, whether it's a holiday, pick a time and stick with it each year. So that way you have an auto reminder of when to go get your mammograms. And just be body aware. Know what's normal for you and know what's not. And if it's not, go get it checked out.
Great advice. Thank you so much. You mentioned earlier some clinical trials and studies that MedStar Health offered. Are there any other trials that our viewers should be aware of, or any other studies happening right now?
There's a lot of trials that we have available. Most trials in the breast cancer world have to do with medical oncology. So most trials have to do with chemotherapy regimens. We do have some surgical trials. The COMET trial for DCIS, which is the one of figuring out whether we should operate or not operate, is one. There is a lot of discussion of down or de-escalating, I guess, how much surgery is done in the armpit, so in the axilla. So there are a couple of trials open looking at that. We have also just kind of health and wellness trials that are available to patients. So, you know, at any given time, we have at least 20 to 25 breast cancer trials that are open and running. Some are available at all MedStar sites, some are available at only certain MedStar sites, but because we are a much larger group, we have easy access to all of them. And so it really is just going to be individualized on what you have going on and what you need.
Thank you very much. Just a few more questions for you. You mentioned chemotherapy just now, and I know you mentioned some of the treatment options a little bit earlier. Does every breast cancer patient need chemotherapy? I think that's usually what you think of. You think breast cancer, you think chemo.
Yeah.
Is that always the case?
No. There's a lot of women now that are treated without chemo. So this goes back to having to individualize treatment for every patient. So if somebody has a hormone positive breast cancer, and it's pretty favorable, there's actually additional testing that we do now, and it's called genomic testing. So it actually is the tumor that you were growing is sent off for testing, and that testing can come back and tell us kind of how high risk or low risk of a lesion it is. Those numbers is what helps then predict, are you going to get benefit from chemotherapy or not? And so if you had a genomic test and it came back as kind of a low score, it means that chemotherapy isn't pretty beneficial to you, so we're not going to recommend it. So instead, we may just be recommending that you take a pill, so like an endocrine therapy, and you may be recommended to take that pill every day for 5 years or even 10 years for some patients. For other patients, you know, chemotherapy is absolutely recommended, and that's because the subtype of cancer they have is going to respond best and be treated best by utilizing chemo. So I never want to give you a drug or recommend something if it's not going to help you. But if it's going to help you, even though everybody is devastated to think they need chemo, if it's going to help you, there's a reason why we're recommending it.
Right. Thank you very much. Treatment question for you from Deborah, different Deborah from earlier. Can you explain more about LCIS for a patient who's diagnosed with breast cancer after a mammogram? And can you explain more about LCIS and letrozole? Is that a medication?
Yeah, so LCIS is looked at as being like a high risk lesion. So this gets a little confusing because LCIS stands for lobular carcinoma in situ, and DCIS stands for ductal carcinoma in situ. Okay. DCIS, ductal carcinoma in situ, is considered to be a stage 0 breast cancer. LCIS, so lobular carcinoma in situ, for most of them are not considered to be a breast cancer. LCIS is considered to be a high-risk lesion, so a marker that will increase your risk of developing breast cancer in either breast over your lifetime. Letrozole is one of the endocrine therapies that we have. And so if it's given because you have a diagnosis of LCIS, it's given as something that's called chemoprophylaxis. So it means that you're taking the medications to try to help prevent the development of breast cancer.
Thank you very much. Last question for you before we wrap up our broadcast. Any final takeaways or anything else that you wanted to share with our viewers?
Yeah, so there is, just because of the region that we're in, you know, there's always a lot of discussion about regional differences for breast cancer. One takeaway that I do try to always give to patients is that we live in the DC metropolitan area. And so if you look at breakdown of incidence of breast cancer by state, Washington, D.C. is one of the highest incidence of breast cancer by state. So if you look at the states, the highest incidence is New Hampshire, Connecticut, Washington, D.C., and Hawaii. And so we look at incidence as number of women per 100,000 women that develop breast cancer. And so New Hampshire is 145 women per 100,000, and DC is 139 women per 100,000. The lowest ranked state is Nevada, which is about 110 per 100,000. The difference, though, is we always want to focus on incidence and then mortality. So what's your risk of kind of developing a breast cancer and maybe dying from it? Mortality also is number of women per 100,000. DC has the highest mortality rate out of anybody in the US, and they have about 26 deaths per 100,000, whereas Hawaii has about 16 deaths per 100,000. So, I mean, it's not a huge difference, but it's definitely a difference. And the reason being is because in the DC metropolitan area, we also have a lot of African-American women. And so while Caucasian women have a higher incidence, so they have a higher risk of developing breast cancer over their lifetime, the breast cancer that they tend to develop tends to be kind of a slightly more favorable breast cancer. So it tends to be a hormone positive one, whereas African-American women tend to develop triple negative breast cancer, which tends to be a little bit more aggressive. And so it tends to spread a little bit more differently than hormone positive. So one of the things that I do kind of always push for is just because of the fact that we live in this region, I do always recommend young women to start their mammograms at 40, just based on geography, but also that it's really important for young women to be, again, body aware, do self-exams, really pay attention to what's happening, because just because you're young doesn't mean that you're going to escape this.
Thank you very much. That is wonderful advice, great takeaways, and some great insight on what's happening around our area. So thanks, Dr. Wehner, for joining us. Thank you to all of our viewers for watching and asking your questions. For more information about Dr. Wehner, you can visit medstarsouthernmaryland.org/Wehner. That's WEHNER. We'll share that link in the comments as well. And to contact the Breast Center at MedStar Southern Maryland Hospital Center, you can call 301-877-5607. Thank you, Dr. Wehner, for your time. We really appreciate it. And we'll see everybody next time.
Thank you.